It turns out that resilience, the cornerstone of mental health recovery, is not just an individual trait, but a dynamic process deeply embedded in social and environmental contexts.
Really? That's quite a shift from the usual idea that resilience is just about personal grit or toughness.
Exactly. It challenges the clinical focus on individual capacity and instead points us toward the systemic and relational factors that either support or hinder resilience.
That makes a lot of sense, especially when you think about how patients, environments, and social supports can make or break their recovery. So, what's at stake here if we don't get this right?
Well, it's huge. How we conceptualize resilience directly influences nursing interventions, the quality of therapeutic relationships, and ultimately patient outcomes in mental health care.
So by the end of this episode, listeners will have a more nuanced understanding of resilience, therapeutic boundaries, addiction management through harm reduction, and the complexities of child and adolescent mental health nursing, all with a clinical lens that emphasizes practical application.
Right. Let's start with resilience. It's often misunderstood as just bouncing back from adversity, right? But the document really reframes it as both a process and an outcome shaped by complex cultural systems. It's not just about personality traits or individual toughness.
So resilience depends more on the quality and interaction of social and physical environments than on individual traits alone?
Exactly. It's about navigating and negotiating resources that support well-being. It's not about being unaffected by stress or never feeling negative emotions.
That's important, because sometimes clinicians expect patients to just tough it out, but resilience actually means recognizing difficult feelings, adapting and recovering rather than being stuck.
Yes, and key characteristics include optimism, a sense of mastery and competence, and the ability to regulate emotions.
I like that it's a holistic view. It means supporting resilience isn't just about teaching coping skills, but also about enhancing access to resources and addressing social determinants of health.
Right. And the reflective questions for assessing resilience are really insightful. Things like what gives the patient meaning, how they respond to difficult times, and what supports they have.
That's a great clinical tool. It encourages us to look beyond symptoms and understand the patient's broader context.
Moving on, the therapeutic relationship is foundational in mental health nursing. It's defined as a helping relationship based on trust, respect, empathy, compassion, and authenticity.
And it's goal-directed and patient-focused, with the nurse being sensitive to self and others, aware of power differentials, and prioritizing the patient's needs over their own.
Exactly. The core relational skills include listening, questioning, empathy, self-reflection, and sensitivity to emotional contexts.
And the essential capacities for nurses are initiative, reaching out and joining patients where they are, authenticity, mutuality, and non-judgmental acceptance.
Important to note that non-judgmental acceptance doesn't mean agreeing with all patient decisions.
Right, it's about accepting the person without endorsing harmful behaviors.
Now, therapeutic boundaries are critical. They're the professional space that protects patients from harm and prevents exploitation.
Boundaries must be established early and maintained consistently. When boundaries blur, it can lead to serious issues.
Yes, warning signs include strong emotional reactions, either positive or negative, over-identification, difficulty maintaining objectivity, or meeting nurse needs at the patient's expense.
That's where transference and countertransference come in, right?
Exactly. Transference is when patients unconsciously project feelings from past relationships onto the nurse. It can be positive or negative.
Like a patient saying, "You remind me of my mother," and then either responding with trust or hostility.
Right. And countertransference is when the nurse unconsciously projects their own feelings onto the patient.
That can be dangerous because it inhibits emotional intelligence and can lead to stigma or harm.
So nurse self-awareness is essential to manage these dynamics effectively.
The nurse-patient relationship progresses through 4 phases: pre-orientation, orientation, working, and termination.
Pre-orientation is before the first meeting, where nurses prepare and address safety concerns.
Orientation focuses on establishing trust, defining roles, and setting confidentiality boundaries.
The working phase is where the real therapeutic work happens, exploring problems, coping strategies, and emotional processing.
And termination is the final phase, reviewing progress and planning for the future.
Consistency, private and paced interactions, active listening, and suspending judgment are key nurse behaviors that enhance the relationship.
Barriers include inconsistency, avoidance, superficial contact, and nurse factors like lack of self-awareness or negative biases.
Now, shifting gears to addiction and harm reduction. Addiction is a chronic, relapsing brain disease characterized by the 4 C's: craving, loss of control, compulsion, and continued use despite consequences.
Cravings can be relief cravings, intense desire after decreased use, or reward cravings triggered by environmental cues or stress.
Reward cravings are often the cause of relapse, even after long periods of abstinence.
Loss of control involves neurological changes that impair judgment and decision-making, reducing cognitive flexibility.
And compulsion is the overpowering drive to use, distinguishing addiction from habituation.
Despite physical health problems, relationship difficulties, and legal issues, patients continue use knowing the harm it causes.
Harm reduction is a philosophy that meets people where they are, focusing on reducing negative consequences without requiring abstinence.
Nurses must examine personal biases, recognize substance use as a health issue, and understand trauma's role to practice compassionately.
Harm reduction strategies span primary prevention, like education and naloxone training, secondary prevention with needle exchange and supervised consumption, and tertiary prevention including supportive housing and medication-assisted treatment.
Medication-assisted treatment combines pharmacology and behavioral therapy to target cravings and relapse.
For alcohol use disorder, medications include disulfiram, which causes acetaldehyde buildup, leading to unpleasant reactions if alcohol is consumed.
Naltrexone blocks dopamine release, reducing the pleasurable effects of drinking and decreasing relapse.
Benzodiazepines, like lorazepam and diazepam, manage withdrawal symptoms.
For opioid use disorder, methadone is a full agonist with a slow tolerance development, while Suboxone combines buprenorphine and naloxone to lower overdose risk.
Naloxone is critical for overdose reversal, acting rapidly to reverse respiratory depression.
The case of Jim, a 45-year-old with alcohol use disorder, illustrates clinical assessment with a CIW-AAR score of 16, elevated heart rate and blood pressure, tremors, mild ataxia, and irritability.
Nursing goals for Jim include safety during withdrawal, reducing symptoms to a CIWA score below 8, and engaging in addiction treatment with coping strategies.
Finally, child and adolescent mental health is complex and often underdiagnosed. 1 in 7 Canadian youth is affected, but 2/3 don't receive needed services.
Suicide is the second leading cause of death in youth aged 10 to 19, highlighting the urgency.
Barriers include lack of parental knowledge, stigma, limited access, cultural factors, fragmented systems, and provider shortages.
Risk factors are multifactorial: genetics, adverse childhood experiences, parental mental illness, abuse, neglect, and social determinants.
Exposure to intimate partner violence and neglect are common, with males experiencing more physical abuse and females more sexual abuse.
Assessment includes developmental and mental status exams, risk assessment, and family and cultural context.
Interventions range from family and group therapy to cognitive behavioral and behavioral therapies, milieu management, and mind-body approaches.
Neurodevelopmental disorders like intellectual disabilities, autism spectrum disorder, ADHD, and learning disorders require specialized approaches.
So to wrap up, this episode reframes resilience as a systemic process, underscores the critical role of therapeutic relationships and boundaries, deepens understanding of addiction and harm reduction, and highlights the complexity of child and adolescent mental health nursing.
These insights challenge us to approach mental health nursing with greater nuance, self-awareness, and systemic thinking to improve patient outcomes.
Absolutely. It's a reminder that mental health care is never just about the individual. It's about the environment, relationships, and broader systems that shape recovery.
Well said. That's a wrap.